Okay, so good morning, everyone, or good morning or good afternoon, and welcome to today's webinar. This webinar is brought to you by the Uganda Virus Research Institute and the Global Health Network. Today, our topic is how to navigate practical research challenges during the COVID-19 pandemic, the African story. My name is Professor Pontiano Kalebu. I'm delighted to be joined today by Dr. Jen Achan, Dr. Sylvia Kwedi-Nona, Dr. Jennifer Serwanga, and Dr. Joe Bonnie, and I'll be introducing them shortly. But before we start, I'd like to give you some housekeeping information. First of all, the session is being recorded. The recording will be shared in the coming days on the Global Health Network platform so that you can review materials and share with others. These materials can be found using the link that has just been shared with you in the chat box. All that will be shared with you shortly. Now, to interact with the panel, please use the Q&A or the chat function box, which you can find on your toolbar. And if you have any technical issues, please let us know in the chat, and the Global Health Network team will aim to assist you. We have dedicated time allocated for Q&A so that you'll be able to try to get through as many questions as you can. If we don't have time for all the questions that you'll be posing to us, we'll save them and we'll try to share written responses along with the recordings that we're going to do now. Now we're going to begin the program, and what I will do is to introduce all the speakers now so that you know who is with us. We are very delighted. First of all, I want to thank the panelists who have agreed within their busy schedule to come and talk to us. We shall have Dr. Jen Achan, who is a senior research advisor at Malaria Consortium in the United Kingdom, where she oversees and supports the research programs across 11 countries in Africa and Southeast Asia. Dr. Jen will be talking about challenges and strategies for conducting clinical research during COVID-19 experiences from resource-limited settings. A very important topic and presentation. We are also very delighted to have Dr. Sylvia Kwedi-Nona, who is a senior lecturer at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé. Her research career is marked with spearheading internationally funded epidemiology and public health projects in Africa. She is the founder of CLEAR, that is Capacity for Leadership Excellency and Research, a consultancy firm that aims to build operational capacity of health programs and research activities in resource-limited settings, particularly in Africa. Dr. Sylvia will be sharing with us a topic on stakeholder management for research during epidemics. Again, a very important topic. We shall then have Dr. Jennifer Serwanga, who is a senior immunologist, assistant director immunology at the Uganda Virus Research Institute, and is a principal investigator on immunoprofiling the immune response to COVID-19 in sub-Saharan African settings here in Uganda. And she's also a PI on another project that is developing an inactivated COVID-19 vaccine here in Uganda. Dr. Jennifer will be talking about sample collection and setting up of a biorepository during an epidemic, our experience at UVRI. another very important topic. And finally, we shall be having a presentation from Dr. Joy Bonnie, who is an energetic emergency medicine specialist from Ghana. He trained in the Ghana College of Physicians and Surgeons, currently pursuing his fellowship program in adult emergency medicine with the same program, and the fellowship in disaster and emergency preparedness from the sunny Downstate Medical Center in New York, USA. He currently works as an emergency medicine specialist, attending at the Comfort and Noche Teaching Hospital's Emergency Medicine Directorate, current Vice President of the African Federation of Emergency Medicine. Very, very important and nice to have you here. And he'll also be delivering on the topic, integration of research study findings in public health programming. So join me in welcoming these excellent and very renowned researchers working in Africa and in different parts of the world. And now I will invite them to start their presentations. I think we are starting with Jen Achan. Most welcome, Jen.
Thank you, Ponsano. So I will request the Secretariat for the slides, please. So good afternoon, everyone, once again, and thank you for joining us on this webinar. Like has been mentioned, I will be sharing with you on the challenges and strategies for conducting clinical research during the COVID-19 pandemic, and largely sharing some experiences from resource-limited settings. Next slide. So in terms of an introduction, we all know that the ability to conduct research during pandemics is particularly important, especially in situations where the pathogens are novel, like we currently have with COVID-19, but also when the corresponding therapeutics are not known or in need of validation, and where also we need a good knowledge of epidemiological profiles to be able to inform the response. We have also seen over the last couple of months that pandemic containment and mitigation strategies, which have caused widespread social and economic disruptions, have also had a major impact on the different research activities that the different groups have been able to do. Now, this presents unique challenges for research, especially in resource-limited settings, and that this could significantly and negatively impact on the contribution of these research-limited settings to important SARS-CoV-2 research. Next slide. So the observations that I'm going to share during this talk are really what we went through when we were conducting a study that was looking at the clinical interactions between SARS-CoV-2 and malaria in a highly endemic malaria country. This was a prospective cohort study that we conducted between 15th April and 30th October in 2020. The study was conducted across different COVID-19 treatment centers in Uganda. And in terms of the sample size, there were 600 PCR confirmed COVID-19 cases. A number of observations were done in this population. We did malaria diagnosis using 3 different approaches for malaria diagnosis: rapid diagnostic tests, microscopy, and molecular methods. We also conducted a complete spectrum of clinical labs, the complete blood count, liver, renal function tests, and HIV tests. Next slide. Next slide. Oh, yes, okay. So in terms of the other research-specific investigations, we also did a spectrum of different immunological profiles, largely looking at previous exposure to malaria. We did an extensive of markers of inflammation, including C-reactive protein, a couple of interleukins, and also tumor necrotic factor. To be able to ensure that we had an independent lab team, all the lab personnel who were working on these samples were completely unaware of the clinical status of the patients to avoid any potential bias. And in terms of clinical management, all the treatment centers performed clinical management according to the standard Ministry of Health and World Health Organization guidelines. So this is really a background of the research context that I will be describing. Next slide. So one of the main things that we need before we initiate a study is ethical approval. And in these settings of the pandemic, we know that the need to learn as much as possible, as quickly as possible, is of utmost importance. But in these settings, the key relationship between the epidemic response and research raises a number of ethical and regulatory challenges. We also know that ethical review is required before the launch of any research activity, but the unique circumstances of this pandemic really call for special considerations for modifying the different ethics procedures that are warranted across the different settings within which we work. Because of the emergency setting and the need to really accrue data rapidly, expedited approaches to ethical review and approval are required to facilitate timely initiation of research activities. And of course, for this to happen, these approaches need to be supported by existing national or international regulations and guidelines. Next slide. So in the context of the study that we were conducting, we had to submit to the ethics committee at a time when the ethics committee could not meet physically. This was at the height of the first wave of the pandemic in Uganda, and we basically had an absolute lockdown with no movement according to the country guidelines. So the ethics committee could not meet. However, we had scientific questions that we needed to answer in the context of the pandemic. And for us to be able to do this, we were able to obtain expedited approval and review, and this was done within 48 hours of submission of the proposal. This was guided by existing national guidelines, which ensured that within the context of such public health emergencies, expedited approval could be granted by the chair of the ethics committee, but all expedited review decisions would then need to be presented at the next full ethics committee meeting for ratification and final approval. And with this expedited approval, we were able to launch the study activities immediately and start study recruitment in a timely manner, and this facilitated optimal accrual of study participants. Then in Uganda, we also have a second level of approval, which is the national level. The National Council of Science and Technology is the responsible agency for this approval. And they were also quite responsive in the context of the pandemic. They did provide timely guidelines for researchers on how to manage research activities, when to stop, when to initiate, and what would be put in place to be able to initiate. In addition to that, the Uganda National Council of Technology also had an online electronic platform for submission of research applications, and that ensured safe ongoing and paperless research review that did not warrant, personal contact at the offices. That was the case before. Next slide. Next slide, please. Okay. So, at the start of this study, we had originally planned to conduct the study at 2 treatment centers that were based in central Uganda. And the reason we did that was that at the beginning of the pandemic in Uganda, there were only 2 treatment centers opened for COVID-19 patients, so Entebbe and Bulago. So operationally, we designed the study around these 2 treatment centers that were relatively close to each other and relatively close to the labs that we planned to do the work in. After a couple of weeks, the approach to the management of COVID-19 was decentralized, such that there were several treatment centers opened up across the country. As a research team, we had to immediately change our operational scope from 2 geographically close locations to largely cover all these treatment centers across the country to be able to have a geographically representative population within the country context. So the operational challenges of scaling up to 8 across the country were quite significant. We also had to coordinate these different sites with 4 different laboratories that were all located within the central part of the country. So the transport network and the coordination at these different facilities were quite key to ensure the integrity of the samples from the field hospitals to the central location of the labs. And there were a number of issues also that were associated with this scale-up. We did have the ethics approval letters and a copy of the protocol that we had to present to each of these health facilities. In addition to that, we also had to present a letter of introduction from the Ministry of Health, We had to obtain clearance for conduct of research in each of these facilities by the health facility leads. For some districts where the research team had to have an overnight stay because of activities, they had to get permission from the district leads to be able to spend the night in these districts. And this was largely because of tracking really and ensuring that all movements were well monitored. And because of the increasing number of patients in some of the facilities, we also had to support the personal protective equipment supplies that these different treatment units required. Next slide. So this is just a couple of photos just to share the innovations that we conducted. So training sessions were largely one-on-one to ensure that we are not crowding in different locations. And as you can see, they were largely outdoors. Some of the training sessions were really done in a very minimal period of time with the different teams. So the clinical teams, the lab teams, the nursing teams, we had to train them innovatively. And of course, peer support to ensure that all the SOPs were being followed, preparation of the different sample collections to ensure that they're taken to the right lab. And of course, here was the study coordinator at the end of the day, delivering the samples to one of the clinical care labs. So quite a busy kind of field activity. Next slide. So one of the important components of research is really consent. We know that informed consent is a prerequisite for research participation and is both an ethical and legal requirement. For this study, we were required to obtain written informed consent from all participants and using either signature or thumbprint. Now, because we are working across 8 different health facilities and there were multiple groups working in these health facilities, we had to fit within the organizational aspects of these health facilities. And for most of these treatment centers, the designated areas were 2. The admission area, which was a highly infectious area, was what was called the red zone. And the administrative area where people took a break after different periods within the red zone was called the green zone. So multiple research teams had access to the administrative area, the green zone, but access to the red zone was restricted to the health facility staff only. And of course, once the consent forms entered the red zone, there were concerns about the potential for formalin transmission from these consent documents. And at the time we conducted this study, there was limited data on the duration that these droplets spent on paper and how long they would remain infectious and what risk that imposed for transmission. So we went through a couple of considerations on how best to handle consent forms that had been handled by patients within the red zone and had to be taken out of the red zone to ensure that staff were not exposed to infection. Next slide. So a number of options. So one of the options was legal consent forms within the red zone and take them out at operations were a little slow and safer, but this raised the long-term safety of such important study documents in the restricted, in such public spaces within the admission wards. And the second option was remove every completed consent form from the red zone after each enrollment. And this is the approach we ultimately used. And we did this by ensuring that after every consent form was signed, they were placed within a plastic biohazard bag. As they left the consent form, the red zone, they were disinfected and subferred into a second biohazard bag for protection, and then stored in a safe location until they were ultimately removed and disinfected. Of course, the other challenge was how do you disinfect these consent documents? And we discussed with a couple of different research groups. And ultimately, the decision was to use ultraviolet light in an automated disinfection system to disinfect every single page of the consent form. The other challenge with consent is how do you consent a severely ill patient who is on a ventilator and most times has no next of kin available. So there was a lot of effort to identify and locate the next of kin for some of the patients who may have presented unconscious, but in a couple of situations when there was no designated next of kin, these participants were not enrolled. Next slide. Of course, these are just some of the pictures to show what we actually did with the consent forms. So the consent forms left the red zones in biohazard bags that looked like this after the disinfection with disinfection sprays. We then stored them in these plastic containers within the research storage room. And when we were able to identify an approach to disinfection, we used a hood, an ultraviolet light in a hood that looked like this to ensure that every page of the consent form was disinfected. Next slide. So there were also a couple of considerations on how best the research staff and the clinical care teams at each of these health facilities interacted. At most of the treatment centers, the treatment center heads were hesitant to have multiple research groups entering these centers. So you can imagine 10 different research groups working on the same patient population. It was simply not possible to control that traffic in and out of these highly infectious patient treatment areas. So the decision that was made in meetings with these different treatment centers was to have the primary clinical care team, so that teams providing care at each of these treatment centers were given the responsibility to perform all the study procedures. And this included obtaining consent, sample collection, and data collection as well. Of course, this called for staff training to ensure that there was consistency in the performance of procedures across sites, and also because we really needed optimal adherence to the infection prevention and control procedures and to minimize exposure to multiple individuals from different research groups, this was considered an ideal approach. So, and in discussions with the clinical staff, they were fully supportive of this approach, and they facilitated scheduling of different research activities across the different research groups. And this ensured compliance by all groups and also ensured that the workload was minimized because of the scheduling that was done in close collaboration. Next slide. We know that for most of the research that we do, participant compensation is something that our national guidelines in Uganda require us to do for the time these participants spend in studies. Ideally, in the routine settings, this is done by a direct cash payment to the participants. But because these patients were really in a highly infectious state, direct cash payments were generally discouraged. And while the research participants were still hospitalized, still because of the risk of transmission with fomites. So the ideal approach we used was a digital platform, or what we call the mobile money platform, to ensure that patients were received their compensation according to the national guidelines. And for participants who did not have this platform, they provided maybe a contact number for the next of kin so that the compensation was done in time. Those who completely did not have accessibility to this were compensated at the time of discharge. But of course, this also raised a couple of issues because it was perceived as a potential delay in actually providing the compensation that they should have been provided. And because you have to provide your number and the name for this transaction to take place, there was a lot of stigma associated with providing these details to non-medical staff. So this is really a function that the administration or the finance team of the research groups would pay. But because of the stigma of really providing a name and a number for a non-medical personnel, we had to ensure that the study coordinator, who was a clinician and had been interacting with the patients, actually did this electronic payment to ensure that there was a maintenance of confidentiality in these settings. Next slide. There were also a number of psychosocial needs of patients. I know that we focus on research, but because we are working on a unique population, there are a number of psychosocial needs that we realized. This was not a primary study objective, but we did encounter significant issues related to the psychosocial needs of both the participants and the health workers. We do provide a telephone contact on each of the consent forms that we give these participants. And what we did not know was that this phone contact became an unintended helpline used to address patient concerns about several issues that were mostly outside the scope of the study. And well, fortunately or not, it was my number that was on the consent form. So I really was manning a helpline to ensure that in addition to the valuable information they were providing, we could also respond to their needs. And the complaints were quite numerous. Long hospital duration, especially for asymptomatic patients who at that time were hospitalized according to the national treatment guidelines, a number of requests to improve aspects of well care, feeding, personal requirements that they didn't have. There were significant complaints about delay in receiving COVID-19 tests, queries about study compensation, a lot of stress related to confinement within these treatment centers away from family, and then largely fear of stigmatization. So as a study group, we attempted to respond to most of these, and for those that we could not respond to, we provided this feedback back to the clinical care teams for follow-up and appropriate management. Next slide. So we also had a challenge in that there were a couple of research teams working and a number of research activities being conducted on the same patient population. So multiple research groups working at the same treatment centers, and significant overlaps within the research activities on the same patient population. And patients really went multiple assessments with numerous samples that were collected for different tests. So there were routine clinical labs, there were study-specific sample collections, and there were also COVID-19 follow-up diagnostic testing that was being done on the same patient population. And the challenges we faced with this was that patients expected formal feedback for each sample that was collected. They really did expect a lab result for each of these samples. Some studies were unable to return results because many times some of the samples were collected for biobanking or for storage, like we will hear in the subsequent talk, and they were not available for the patients until they had left. And because of this perception that a lot was being done with no feedback, in some instances, the patients who came subsequently actually refused to participate in some of the studies because they felt like there was no benefit from prior participation in the earlier, observations that had been taken. Next slide. So challenges about the feedback on lab results. Largely, most of the clinical labs were available immediately and they all participated or were used to facilitate patient care. The biggest challenge was with research-specific specialized assays that were often unavailable during the period of hospitalization. And we think this should really have been communicated better by the different research groups to the patients. And then, of course, at times, the different research groups did not also provide adequate explanation for the various assays and the possible turnaround times. And overall, we think better coordination between the research groups could have streamlined some of these operational aspects. In fact, in one of the largest treatment centers, 3 different research groups had a collaborative agreement in place just to streamline communication and the different research procedures. For example, if one group was doing a particular test, the agreement was to ensure that the different groups have access to that test result instead of repeating the procedure again independently. Next slide. So in terms of conclusions, I think some of the observations and the learnings that we were able to see in this study is that while conducting research during such global health emergencies is challenging, I think the COVID-19 pandemic should really compel the scientific community to innovate solutions to standard research practices that may be difficult to implement in such situations. Ethics committees and investigators should also be quite responsive to challenges by updating policies and procedures around research reviews and approvals, consent, compensation, and modify research methods when appropriate. I think we were able to demonstrate that if we use more adaptable and innovative approaches, we should be able to implement research even in such global health emergencies. Next slide. Overall, I think some of the approaches that we've shared are generalizable to similar settings across Africa and other settings to support timely implementation of clinical research during such emergencies. And I think it's quite key that the necessary changes in policies and procedures that we've highlighted during this pandemic should have a positive and lasting impact on clinical research in other similar situations that may come. And the last slide. Thank you very much for your attention.
Okay, thank you very much, Jen, for that presentation. I allowed you some extra time because we even started late, so there were a few extra time, but the next speakers, let's keep to the time. But I think that was very good, and there'll be a lot of discussions at the end. It was interesting. So we want to go to the next presentation. Dr. Sylvie Kwedi, could you please start your presentation?
Hello, can you hear me?
Yes, we can hear you.
Okay, great. So I'm Sylvie Kwedi. I'm an epidemiologist and a senior lecturer at the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1 in Cameroon. Next slide. I'll be talking about stakeholder management. So this pandemic really took the entire world by storm. It's incredible that 2 years later, practically 2 years later, we're still talking about it. The impact is devastating. It's devastating on every aspect of the world, and research also is a victim. Unfortunately, this is a health emergency, and research activities have to go on. We cannot stop, regardless of the difficulties. Slide. So first, I want to define stakeholder management, which is defined as a process by which relationships with stakeholders are organized, monitored, and improved. It's different from stakeholder engagement, even though stakeholder management is part of stakeholder engagement. But I think that we hear a lot about stakeholder engagement and not the aspect of management when it comes to stakeholders. So of course, we have to identify our stakeholders from the very beginning, analyze their needs and expectation, and plan how to engage with them. But throughout a study, or a research project, we have to manage, and that becomes quite difficult when it comes to doing it during a pandemic. So when we talk about stakeholders, we had to kind of situate ourselves. We're not only talking about the patients that we're working with, or our scientific collaborators on the field that we're working with. We're basically talking about anybody who has a vested interest in the work, and anybody who can even influence the work that we're doing. Slide, please. So here are some examples of stakeholders, the community as a whole. Here I'm talking about the specific realm of public health or health research. Within the community, of course, we have the patients that we are working with, but we also need to keep in mind that we're working within communities, and there are civil society, and of course, national governments in the country where we're working. But not only national governments, any type of government, local, regional, county government, all of them are stakeholders. The media is a major stakeholder, especially in this pandemic, where there's information flying all over the place, whether it's correct or not correct. We see how important the media is as a stakeholder in research. The private sector, the research institutions, international institutions, and I mean like the big multinational institutions like WHO, UNICEF, and any type of institution that involve more than one country. And there's many, many others. I cannot list all the stakeholders here. Slide. So in terms of the challenges that could be faced, that would get us to think a little bit deeper when it comes to stakeholder management. I conceived this presentation keeping in mind the work that I'm doing here in terms of COVID-19 research in Cameroon. So these are just some of the challenges that had to really get us to think about how we manage our stakeholders. the main one, I think, was the PPE, the personal protective equipment, and safety as a whole when it comes to doing research. Even though the pandemic came when we had a number of research projects already on, we had to think about how to protect the patients, the participants of the research, our staff, and anybody else that would have any kind of face-to-face interaction when it came to project activities. And most of the time, this PPE was not budgeted for. So we had to figure out a way to protect the research, to protect the participants with something that was not budgeted for. That was a main challenge that we had to deal with. And we owed it to our stakeholders to make it happen, regardless of the lack of budget. We just had to devise ways to make it happen. Next slide. We also had quite a bit of challenges when it came to patient recruitment and missed follow-up visits. Now, this particular challenge involves not only the participants that we are recruiting and that we're following up into our study, the staff, the scientists, but also our funders and our international collaborators, because we had a particular protocol with a number of participants to recruit, and all of a sudden, the health facilities where we're working had very, very low frequentation rates, I mean, very, very low visits. So how can you be expected to meet your recruitment goals or recruitment objectives when the patients are not coming into health services, into health facilities? The lack of visits was due to stigmatization, because the patients were basically saying that, no, there's a pandemic, I'm not going anywhere near a health facilities because that's where sick people are. And they were afraid of risk of contamination. And also because of that, when you were expecting them to come back for follow-up visits, it was practically impossible. It was very, very arduous to deal with the research participants and also try to keep up with the protocol that you are obligated to implement. Slide. Another challenge was the health system itself. We work with in health, research for health, and we get into a situation where we have to conduct research activities. Meanwhile, research activities that are requiring resources from the health system, but the resources from the health system are basically sucked up by the pandemic. So that made it extremely difficult. I found myself, here's an example. I found myself, for example, where I had the clinical characterization protocol for COVID-19 here ongoing. And it was agreed that the government would actually take care, they would take over the care of the patients once the research team has diagnosed a patient positive with COVID infection. But there came a time where our patients could not be taken care of by the government because the health system was completely overwhelmed. So now you have a research participant, at this point, he's positive for COVID, so he's the patient that needs care. And you sign the consent form that the government will provide care, and the government was not able to provide care for these. That was definitely a challenge that needed to be managed. Slide. Also, managing at this distance was an issue. Many times we could not go into the health facilities themselves because of social distancing. We could not conduct some activities because of social distancing. We could not even hold some meetings because of social distancing. So that was also quite a challenge that needed to be managed in terms of what the stakeholders were expecting. Slides. So I could spend a lot of time talking about challenges because there were many. But what this pandemic taught us in terms of running a research project during the pandemic and managing stakeholders is that we basically had to figure out and compartmentalize what would enable the best management processes and the challenges so that we would know how to act. The enablers were basically carefully planning the project, really minute planning. We had to be on top of it minute by minute so that we would know exactly what to expect at the very next step. The type of team that we had also had to be extremely effective and extremely competent. We could not really deal with inexperienced staff. We had to deal with people that were experienced enough to know how to handle stakeholders in terms of challenges. We had to do quite a bit in terms of engaging non-academics, the community leaders, anybody that would actually help us in managing the stakeholders and their expectations. We were fortunate that the study, the COVID-19 alert study, clinical characterization study that we are running had adequate funding, and we also gave ourselves adequate time to do it. But those are the enablers. But at the same time, we had to keep visibility in terms of challenges. We had major challenges with data because you're working in an emergency situation. And just like right now, the internet doesn't always work. And we were using electronic data collection. So those are challenges that we had to deal with. Building and maintaining relationships. It was kind of a frenzy situation, but we could not ignore the relationships that we were building. We could not ignore the relationship that we had built with the government because we were working in very close partnerships with the government. And by the government, I mean the health districts. We could not ignore our sites, our clinical sites, and those people that were working in the sites. So those relationships have to be constantly maintained, constantly. We had to really have open channels of communications where we were in constant contact with them. The culture itself. Now, I had to say that the most challenging in terms of all those stakeholders that I listed before was the community and the participants. Now, when I'm in the culture, I'm Cameroonian, I work in Cameroon, I was born in Cameroon, live in Cameroon, work in Cameroon, I know the culture. But in this pandemic, it was so difficult in basically just talking to people and getting them to understand what the research was needed for because of the, what did they call it, infodemics, or the misinformation that is out there. That proved to be the most challenging aspect of the study. Slide. So there were many challenges, but in terms of solutions, I found this picture that really spoke to the solutions that we used, some of them, and that we also would learn in terms of lessons learned for stakeholder management. We did a lot of video conferencing because we could not meet face to face, but it is extremely, I'm talking as if the study is over, it's not over, it's still going on. It is extremely important to keep the communication lines open. So the video conferencing helped quite a bit when the internet was with us. sometimes it wasn't. We basically had to focus a lot of our energy on our stakeholders, on our patients, the community as a whole, our collaborators, local and internationally. We had to make sure that everybody basically knew that our ear was always open. And accommodating stakeholders, that I cannot even begin to tell you so many situations where we had to bend, we had to twist in order to make sure that our stakeholders' expectations were met when it comes to patients, when it comes to the research institution that we work within, when it comes to our collaborators. It was the onus was on us to make sure that the expectations were met. And when the expectations were not met, we basically had to explain, because that's just, we had a lot more to lose than them. We have the objective of running this research to completion. And the last solution is closing the feedback. We could not leave any open ends or any unlooped issues. Slide. So in conclusion, we had a few tools that we were able to use. I cannot say that we did very, very well, but in such unprecedented times, we really did the best we could. And I think that we were still able to meet some of our objectives, even though some of them just inherently could not be met. Slide. And I thank you very much for your attention. I hope I was within my 15 minutes.
Yes, you're within time, and the internet did well. Yeah, so that's very good. So let's move on to the next presentation. That's Jennifer. Talk about sample collection, safety of study staff and laboratory during epidemics. Jennifer, it's your turn now.
Thank you very much. Good afternoon, everyone. I come in after I've had many issues that cut across, so it is going to make it very easy for me. I'm going to talk about our experience at UVRI in setting up and following up an epidemic, but really following up people who had been infected, and how we went around with challenges and how we managed to come up with a repository. I'm going to work around key issues that really affected us, which start from regulatory, funds, staff and participant related issues, as well as travel restrictions, and we needed very good quality specimens. So this was an epidemic. This was new. We didn't have protocols, but we needed to understand our epidemic. So the first case we had in Uganda was on the 21st of March, 2020. And as soon as this case was detected, there was a lockdown. We had interest in understanding. We knew that COVID was elsewhere, but now that it was in Uganda, we needed to understand how the disease would develop in our own setting, and we needed to understand the immunity, just not at the beginning, but over time. Our experience started low because there were few cases, but these were cases of people who were mobile. They were mainly truck drivers, people who are business-minded. They come in, take goods and go away. So they are not the usual kind of people that you'd expect to participate in studies. So their time matters. The more trips they get, the more money they get. So studies was a new thing to them. So one of our challenges was that you could not collect samples without a protocol. The good thing is that UVRI is the national, was in charge of the national evaluation of kits for the country for COVID testing. So they had quickly and had already come up with a protocol that would be used for their kits testing. But then we realized that we needed to make this a bit more broader, because if you want to understand immune responses, we needed to put in a bit of more objectives. If we want to understand the viruses, we needed to expand the same protocol. So we didn't go to reinvent the wheel. We used an existing protocol that had been quickly approved to add in a few more objectives. And as Jane said in the beginning, the ethics committees were quite fast at getting all these approvals in place. Of course, this was not funded for, and yet we didn't want to miss out on the samples. So we worked around whatever allocations the Institute was getting, plus any other protocols that had some options for collecting of specimens for serology, because ours was beyond just the usual collection of swabs. We wanted blood, and we didn't want only blood. We wanted even blood for cells, which is even more demanding. So we wanted the cells at the right quality. We wanted the cells frozen, processed and frozen within 8 hours. So this is not easy to achieve during an epidemic and during a time when they have locked down the country. The good thing, the government was understanding. We were among those who were considered to be essential workers, but of course, this was restricted for all others. So if you want to reach people, they are in their homes. But then because at the beginning, COVID was a test and isolate approach, all the participants we are looking for were to be found in hospitals, and the hospital was nearby us. And before COVID, we used to work well with the hospitals, both locally near the Institute in Entebbe, but also we had field sites, which we had already had existing understanding with nearby hospitals. So we capitalized on this and went and talked to them and set up memoranda of understanding to help us to particularly follow up COVID participants. We realized that there were also issues for the staff. This was a new disease, and the staff who normally approach participants were not very comfortable with dealing with COVID patients. They were scared that they would get sick. So the general regulations from the National Council of Science and Technology changed, and they required everyone who was doing any follow-up of participants to come up with a thorough risk assessment. So you needed to assess each and every detail that involves handling participants and all issues related to staff in terms of safety, and come up with mitigations. So we needed to come up with these and then go back to the drawing board and train our staff of how they are going to overcome these mitigations. It even had to reach the extent of us providing masks for participants if we needed to approach them, and also ensuring that the clinicians who needed to interact with the participants were provided with the proper safety gear. Because our participants because the approach of the country was test and isolate, we could not really reach the participants ourselves. So the memorandum of understanding that we set up with the hospital was very crucial, and we needed to have very good understanding with the clinical managers of the hospital isolation units. And then because we had strict kind of conditions for our requirements for samples, we needed to make them understand how we wanted the blood collected. Initially, we kind of worked with other institutions that were collecting the samples, but we had challenges. We saw challenges of quality of blood sometimes. Sometimes the blood would come when it's already clotted. It means we could not even get, for that kind of blood, we could not get cells. For us to be able to process blood that could give us cells stored within 8 hours, we really needed to work directly with the hospital staff, those who would go into the isolation units. So we prepared SOPs for them, went and explained to them how the blood should be mixed so that there is no clotting, how transporting of blood quickly was important, and what temperatures it should be transported at. So we worked with them constantly. Even when we got issues, we would go back and retrain to make sure that the quality of blood that we got was good, so that it could address all the plans that we had for future immunology, for virology studies, as well as contributing to the kit evaluation needs of the country. And sometimes we capitalized on sharing of resources with institutions that were already collecting, and some of them had allowed to share with us some portions, some volumes of the plasma that they had collected. But of course, for cells, we really needed to do it ourselves. As an institution, we found it important that we regroup and form a COVID kind of management team, which was multidimensional, including epidemiologists, virologists, data people, molecular virologists, and people who were specialized in diagnosis. And we used to meet every week to discuss issues around how we were approaching the COVID epidemic from our different dimensions. And these meetings were very important because we were all aiming to be able to understand the epidemic using the available resources and using the available approaches for collecting of the specimens. So our staff got used to how to handle, and the staff issues were sorted. The participants were met by the staff at the hospitals. This was good for us, but we needed to follow up these participants beyond hospitals. So we really needed to depend on the hospital initiation to go beyond when the participants were released from hospitals. The good thing, the hospitals had set up some psychosocial groups that used to follow up participants when they were in their homes to help them resettle and to help them to be better absorbed within their communities. And of course, they were protecting them from researchers finding them in their homes. So we had to work behind the scenes with these communities, with this hospital psychosocial support system, to be able to follow up these people beyond the 2 weeks that they were in hospital, because we wanted to see how the epidemic evolves beyond, even up to 12 months and beyond. Now, this came with a few challenges. When we started, eventually, when they started to know us, when we started to meet face to face with these participants, we realized that some of them actually had not understood why they were still being followed up. Since we are not the ones who implemented the consent and information giving, some of them thought that it was one-off. They were told that provide us with samples and we'll pay you this amount of money or something. So the hospital had its priorities, and maybe sometimes they didn't have enough time to explain the information in good detail. So we found people who were still wondering why we were still following them up when they had already left hospital. So we realized that we needed to go back to square one to explain that we are going to work with them for longer time. And it is important that we understand COVID in our own context so that we can find solutions that are relevant for the country and for combating the epidemic in our own setting. Eventually, they understood. Before, they would sometimes even not come up for their appointments. We would wait for them to take their goods and then would hope that they would ring us. Sometimes they didn't, but time reached when they believed in us. At first, they also feared that if we come to them and collect blood, we are going to test and then find that they are positive and take them back into isolation, which they dreaded very much, because their initial isolation was an isolation of being asymptomatic. They were not really feeling sick. So we were recruiting people who were agitated. Yes, they are positive, but they don't know why they should be in a hospital for 2 weeks. They feel as if their time is being wasted. They feel as if they haven't been explained to properly. So we had a lot of trying to talk and getting them to understand why we needed to understand the infection using them who had already got infected. As Jane said before, of course, there were very many groups that were also collecting. So sometimes we would get complaints which we felt they were not really related to our own studies, but we felt that we should still address and make them understand why it is important to participate in research, because the questions for our settings have to be answered using our own environment and using our own participants. Eventually, we reached a stage where they are the ones who call us that I'm around, can we schedule an appointment? They reached an understanding with us and they trusted us. So putting in of more time into consent and informing and reinforming helped us to make this a lot much more easier. In terms of specimen collection, it was not so much of a challenge for us because we used hospitals that we had worked with before, and we had gone there to also sensitize the hospital staff and make them be part of the protocol and input for us, and to make them understand why it was important that we collected these specimens from Ugandans, so that they knew that answering the question about the Ugandan epidemic needed to come from Ugandan patients. So making them understand also helped us to get them to explain this information better to the participants who were already in isolation. We needed these specimens to come with clinical data, and of course we could not access the clinic. So we kind of followed the same format as Jane has previously already told us. We needed them to fill in that information, but we designed the the data collection tools, which they needed to go and help us to fill in so that we could receive them. We also received them in biohazard bags, but we autoclaved them before we gave them to data entry staff to enter them for us. So we were able to collect blood, but also to collect the necessary clinical specimens that we needed. In terms of ensuring that blood was of good quality, collection and processing of blood had been routine in our setting. So we just used the existing knowledge and skill to make sure that we followed the same principles. We already had FreezerWorks laboratory management systems that helped us to be able to document how samples were collected, how long it had taken before freezing, to make sure that all the important information about sample processing was captured. So we just repositioned ourselves to address COVID using existing knowledge and skills that our staff had already been exposed to. And we had concentrated a bit more on making our staff not feel as if handling COVID samples is going to make them sick with COVID. So we found that the electronic data entry system that we had, the FreezerWorks, sometimes was not very reliable, and staff were working under kind of tension. So we just designed a simple Excel data entry form, data entry electronic database that we used to quickly capture the relevant information. And then when staff were free at later time points, we were able to input that into the LIMS that we had, the laboratory information management system. So generally, most of the starting was not easy. We had challenges, but we needed to get the mindset of the participant as well as our staff right to get this working. The fact that government allowed us to be able to move, and the fact that we made the hospitals and the hospital staff understand us, made it a lot easier for us to take off. The main lesson that I would say we've learned from this is that it would be good for all settings to have a global protocol that addresses epidemics in a broad and multidimensional approach. You just set it up and have it approved so that when the epidemic comes, you kind of just take off. Because every time we kept reviewing and adding objectives almost like every week. But if you set it up and it is generic and it is waiting for epidemic, it makes the takeoff much more easier. Thank you very much for your attention.
Okay, thank you very much, Jennifer. You have been within the time. Now I want to move on to the last presentation of Dr. Joe Bonney, who's going to tell us about integration of research study findings in public health programming. So Joe, it's your turn now.
Great. Thank you very much for this. I hope you can hear me. I am going to share my screen. Excellent. So thank you all very much. And I think my previous speakers have done really good justice to the topic at hand. And I am only going to add a little bit because it has become really clear that the process of collecting the data and engaging the community really feeds well into being able to be accepted by the stakeholders for public health programming. I already have been introduced. So let me tell you a story. So there's always the story of the researcher doing a lot of work, and then the story of the community. And there's no link between the two. The fact of the research being moved into public health and moved into policy to affect the individual person at the community level is missed. And in the case of COVID-19, it became very clear that there was no time to gather the data, keep the data, clean the data for a couple of months, analyze the data, and come out with a beautiful scientific paper when there was a need for people to know what was happening. So I'm telling the story about some of the research work that seems to have been able to skip these and go directly into policy planning as we moved along. An example is the clinical characterization protocol, which is familiar to a lot of my colleagues on the call who were involved with this with ALED. And in this case, we just did not pick stakeholders from the local level, but from WHO adapted the protocol. To be very honest, the aim that what made this successful among policymakers was that it was converted into local capacity and resources and very specific with local content to produce a Ghana-ready document, a Uganda-ready document, a Kenya-ready document that could be used in country to be able to serve the purpose. Also, in the coordination scheme of things, we ensured that the COVID-19 management in the country was involved in the process of the work. So not only were you just collecting data, but you were providing resource directly to the COVID-19 management team. We looked at the data that has been collected, and presenting the data in such a simplified manner was very easy for the policymakers to understand. They were having a lot of problems saying that they were not going to look at huge reports and huge messages. Tell me what you have, tell me how I can work with it. But also what made it easy for them to take up is that it was noticed very quickly that people were not working in silos. There were interconnections among these silos in order to provide a comparable result among various institutions, a large data set, and the fact that the impact could be real. With policymakers noticing that there was some connection among researchers, among sites, it was very easy for them to rely on the results and use this for implementation. This is an example of a dynamic dashboard that was shared with the policymakers for them to be able to see real-time data that was being collected in the field. Also, the idea was to work closely with agencies that were in the same space, Africa CDC, WHO, AFRO, ALED, and other partners who were working on similar work. Compare notes, find out what bottlenecks they were having in implementing this in the country, and then work together to move past this. Another example is the health worker survey, which also looked at a quick transformation of a survey document into a local form. In this case, a simple representation to this showed policymakers how many people had been involved and then the scope of the healthcare workers that had been involved. In this, it's very easy for you to recognize that a lot of health workers had been involved in the study with the various categories. So you could directly pinpoint which stakeholder agency will be interested in this. They weren't too interested in multiple chats, but a few got the attention of stakeholders to be able to push for policy. But then the big point was, who do you engage, when do you engage, and what do you tell them? So stakeholder management became a really big problem to be able to get health, public health policy planning to take up the work. This shows some of the work we did on stakeholder mapping, where we picked people with the interest and the power. So high interest, high power in one category, low interest, low power in one category, and so on. And then they were classified under the national government, with society, the media, private sector, research institutes, and network. And I remember Selvi speaking a lot about how the media plays a huge role in getting the public to accept this. Even if it's put into a public health policy, and the media cites it, it'll be very difficult for implementation. So this shows us just a section of the entire graph of where we had people with high interest and high power, and you could realize that the Minister of Health is really prominent in this circle in every country. Looking at giving back to the community and having the community accept this, this shows a schematic of a third prevalence study, which is happening in Ghana at 2 locations. Usually, we have the community, samples from the community, samples to a lab at KCCR, and sometimes it stops right here. But in this case, they went back to the individuals to give them the results, interpret the results, and direct them to care. And all of this was presented to the Ministry of Health to show the third prevalence numbers in the country. Because the community had accepted this, when the ministry was given information about how many people they presumed had COVID-19, it wasn't strange to them, as the community was already aware that I might have had it, did not have symptoms, but then I've had a test that tells me that I was positive. So why will the public health community embrace your research? So now the researcher is not having his work stuck on his computer, but now it is being moved through the Ministry of Health to these. We have already discussed a lot of these challenges: ethical clearance, reviews, implementation, training, politics, monitoring, and more importantly, the race to time, mobilization, and quick relevant output. So these are some of the practical solutions to ensure that your research work comes out reliably and for the public health stakeholders to take it up into public health planning. So pre-designed protocols, which are country focused, discuss discussions of expected expedited review. Have the policymakers understand that we need this done early. The ethics is a really big policymaker, and they are the same people whose hands stretch into the ethical committees who are usually in the public health implementation field. So if they do accept your work at ethics, it's most likely one of them will be on the policy planning to accept this into policy. Then use local staff, apply collaborative funding, and use science as an incentive and not the money. Speak to the policymakers about the good of the science and not how much this will bring to an institution. Open discussions with the leaders at the site and implementation plans of how the work will be done. Early involvement of the public health authorities, even in the implementation of the work, and then use local leaders at the site. For the technology, this allowed us to be able to do active sharing of the data with authorities. If I enter that a patient's data and the COVID-19 task force is seeing this, they could easily use this to change their planning on the next strategies that they will use. For the politics, keep the authorities involved at the start, throughout the process, and keep them updated on all the areas that you're having challenges and how your work is going. Then quickly look at implementation papers. The scientific papers are great, but look at simple dashboards and then outputs in the media, regular media, social media, simple and easy to understand reports to the policy. In your terms of monitoring, have your authority figures as part of your monitoring. Let them understand that the work you're doing has solid scientific footing and that it will be in everybody's interest to implement the results of this and how it will impact. Most of all, it's a race against time, so be ready. Be ready to be able to move in and discuss your policies with them, your research with them, and have it implemented into policy. I have already shown some of the outputs of a dynamic dashboard. And take, for instance, for the top 3 comorbidities, you realize that alcohol was never an issue, speaking about COVID-19 risk factors. But it quickly became clear that alcohol was one of the biggest factors for people that presented with COVID-19, and that a concurrent alcohol campaign would be really good for COVID-19. And this is something that policymakers would really like to do, to put into public health planning. So I did mention before that you had all these beautiful agencies, WHO, CDC, ALERT, Africa Academy of Science. But one thing is, do not forget your own country. Do not forget to speak to your local authority, speak to your Ministry of Health. Don't have your work getting all the praise at the WHO Afro level, but in your country is not implementing such a work. So in practical solutions, simple dissemination of your results in dashboard and emails are very good for getting them to be uptaken. by the policymakers and being put into public health planning. Personal engagement in person or to stay safe, you could do it by Zoom. Have a large stakeholder engagement. Don't just engage health, engage finance, engage education. Have the community on your side by making sure you feedback with some of the results you have. Involve the media. Have feedback for existing policies that are in place and look at how you can support this. And overall, be a good team player. In this, we realize that the global health emergency has led to a lot of research and output, which has improved healthcare treatment, which should feed into public health policy for improved healthcare for the greater good, and not forgetting the feedback of healthcare policies and improved healthcare for the greater population, feeding back into the research that we do. Thank you very much.
Okay, thank you very much, Dr. Joe, for that very good presentation. Now we're going to open for Q&A, and we have two ways. Of course, you can post your question in our chat, and I think some have been coming in within our Q&A chat, within our other chat. And I'm going to be working with the Global Health Network to help me respond to some of your questions. But you can also raise up your hand, and I'll be checking around for those who have raised their hands. So should we start with, Nicole, should we start with there are some that have already been posted here, and they answered. So I don't know whether the panelists, two ways, the panelists could also check. There are a few questions that have been posed to specifically to some of the presenters, and others are general. I think let's see. Such a what kind of? Let me start with one. Jen, there's somebody who's asking, did the research cover some hard to reach areas of Uganda? And what kind of approach the team used in engaging a group with low level awareness and ill-informed about COVID-19? Yeah, I'm sure you face some of these issues and the challenges. Jen, can you try to address that?
Yes, so thanks for the question. So in terms of the coverage, we covered a fairly wide geographical scope of the country. Most of the centers were accessible, so the only challenge would be the distance, especially if you had to bring back samples in a steady state to the central lab. So none of them were hard to reach. We could reach them, but it's just that there was an extra effort in terms of the distance and ensuring that the samples were back to the labs with good integrity. In terms of the patients, I think most of the patients were generally quite aware about COVID. They were hospitalized and they had been communicated to for having a positive PCR test. The biggest challenge we faced was with the asymptomatic patients who had been found positive because of a test done, but had no complaints at all. And yet the treatment protocols then ensured that they had to be hospitalized for a period of at least 10 to 14 days. So that seemed to be the biggest challenge in terms of explaining why, even if they did not have any clinical symptoms, they had to be kept isolated because of reducing transmission. But ultimately, with communication and responding to their concerns, all of them were quite understanding. Yeah.
Okay, there's another one for you again, and I think this applies to others because it's quite general. Were there any staff in your study team that tested positive for SARS-CoV-2 during the period of participant recruitment?
Okay, so we did not have
actively screening. Yeah, go ahead.
Yes. Yeah, we did not have any staff that tested positive. We were actively screening all the participants and ensured, all the staff, and ensured that we had sufficient PPE for both the study staff and the treatment center staff that we were working with. However, just to note that some of the health facility staff in some of the areas did test positive during the course of that first wave in the country. So no study staff, but some health facility staff did test positive.
Okay.
Yeah.
This
Hello.
one, go ahead. Yes.
Yeah, so I wanted to address that question also.
Yes.
Actually, yes, we did. About 50% of our staff ended up testing positive, me included. And being out for a while, but it was actually good because we actually ended up experiencing the disease itself, which gave us a different type of outlook in working with the research participants.
Mm-hmm. Okay. Many of you, it was interesting to learn how you treated your consent forms, you put in biohazard bags, disinfecting, and all that. You took all the precautions. And some of you started, of course, when there was a lot of information that was not clear, how long the virus remains on the paper and all that. Somebody is asking, concerning biosafety and informed consent form, studies show that the virus does not survive long on paper. We store the consent form papers in a bag for 48 hours and then take them out without disinfection. Do you think this is sufficiently safe? Can somebody just allay the fears, the anxiety in this pandemic, how you treat the consent forms? Is this approach enough, good enough, safe? Yeah.
I think this is Jennifer. I think you need to look at also the perceptions of your own staff. Sometimes we do these things and we think it is not safe. Okay, it has been shown that maybe paper does not make the virus survive for long. But what about those people who have the fears, the people you are going to take the papers to? Because we cannot say we have concluded 100% that the paper is safe. So if you have mechanisms of ensuring safety, I think it is good to make your staff settle other than being worried that, could I get infected from these papers? If you have a mechanism of disinfecting, I would rather that you do that, because it didn't take long for us to be autoclaving, and then you provide it and people feel more comfortable with it.
Mm-hmm. Mm-hmm. And of course, the next one could be answered, Joe, Dr. Joe, any others, Sylvia. You're talking about papers. In this era of reduction of transmission and all that, somebody is asking, were your data collection tools electronic or paper? I know some of you have talked about paper and all that. I think this person wants to know, you should have used more of the electronic tools to reduce on all these risks. This is something that we have discussed before. That's what this person is saying, in reducing infection during this pandemic. So the use of electronic tools, paper tools, what comments do you have?
I can comment on our setting.
Okay, go ahead. Yeah.
I can comment on our setting. You go into a situation where clinicians have always been writing their clinical notes on paper. You don't want to change so many things. We didn't even have the electronic tools to give them, but they normally write their clinical notes. So we were not going there to change how they work. But in one setting, when we went to Masaka, we tried to come up with a way of, we introduced a scanner and put a computer in there so that they could scan for us and send electronically by email the information to us. So where possible, we tried, but where it was not possible, we really were fitting into what they already practiced under normal circumstances.
Okay. Any other comment? Anybody wants to comment on how you?
Yeah, this is Joe from Ghana. I also wanted to comment on this. So the new normal was very difficult for everybody. There had been changes in the clinical work, and whenever you had to come in as a researcher to add on to the changes, it made it really difficult for them to accept the work. So just as the previous speaker said, you try and fit into the system they had. If they were not using electronics so much, you could only do that among your research team, but allow the system to run and find a way of protecting your team to be able to gather the data in the normal clinical setting that they were working in. Thank you.
Okay. Very good. Somebody was asking, that's Prudence Hamadi, that's about the helpline. it seems that from the presentations that she had, the helpline will be helpful to address participant concerns. Do you think we should formally budget for these helplines? And who should man such helplines? Clinicians or a person with social background who understands communities? Do you have helplines in your studies? Any of you can address this.
Okay, maybe I can start. Having received a couple of the phone calls during our study, I think a lot of the issues that these participants had were social issues. So anxiety, fear, questions not answered. So the helpline is quite important. It also facilitates your retention in care for the patients that you've enrolled. But I think a person with a social background would be ideal to ensure that the burden of issues, which is psychosocial, are well addressed. And for the few clinical issues, this social person could then, relay the complaints to the clinicians to follow. So a helpline should be part of the research planning, and a social person, I think, would be ideal to man that. Thank you.
Oh, okay.
Let me also weigh in with this.
Yeah, weigh in, yes.
So the helpline is amazing, and we currently have experience with running a call center for a clinical trial we're running here. It puts the participants at ease, just knowing that they can call. And to be very honest, and we've had only about 10% of our participants calling, but all the rest are very comfortable knowing that there is a number they can call. And to stay very safe in medical practice, it's only for you to pick up symptoms and direct the person to care. So it really is efficient and effective. And I think that looking forward, we should look at incorporating helplines in our research, especially research with follow-up, and it will really reduce our attrition rate in clinical research.
Okay. We're about to come to the close because I know we're running out of time. But I wanted, this is from me now. We have been in the pandemic, and all of you have really given very good presentations, how you managed to do your research under these very challenging times. The researchers did their best, regulatory ethics committees, everybody did their best. I know Jane and a few others hinted on it. What are they, and Jane had a slide, but you could tell me, each one of you tell me, what is best practice? What has this pandemic taught us that can help us to research even better, that we can carry forward even without the pandemic, that we can see that we have improvised and made our research easier, reviews easier and all that. Of course, out of the bad, sometimes the good can come. What is the good that we can get from this pandemic? Anybody can answer this.
This pandemic taught us to work together. You couldn't set up and do everything in one setting. Some people start earlier than others. We realized that working and coordinating between institutions was very important. Of course, the pre-existing work helped us to be able to switch it into COVID, but good relationships with the hospitals and strengthening these also helped very much to make the work flow smoothly. It is good to keep the people who are involved in the work informed, because when something is new, if you don't answer their questions, it could affect. So meeting regularly and giving information and working together with different institutions became better, I think, than we were before, and it is important for any future epidemics.
If I could also add, I think one of the best practices that we could take forward is the approval processes. I think having the expedited approval processes was quite key to ensure that timely study initiation And of course, having standardized protocols. If there's a protocol that is working in Uganda, it should be able to answer the same question in Ghana, for example. So having standardized protocols that are ready to go when something similar happens, I think will be quite key and will also facilitate comparisons across the different settings. So for me, the two ideally would be some lessons and best practices that we could build on.
Okay, very good. We have, I don't know how we're doing with time-wise. I think we are running out of time, but I can see a hand up from Musa Maji Yakub. Yeah. Is Musa Maji Yakub on? Is muted. Okay. Nicole, how are you doing time-wise? Is it time to close?
So, Bongiorno, yes, I think Musa's microphone is not working. So I think we can end up in that note. I just wanted to thank all the panelists for this amazing session today.
Okay. Okay, thank you so much, all of those who have participated. And for those who have sent questions and who have not been able to answer, we'll make sure that these are answered and will be sent with other materials. Once again, thank you for participation, all the participants, the panelists, the organizers of the Global Health Network and Uganda Virus Research Institute, the supporters, EDCTP, and many others. Thank you so much. I think we have all enjoyed, and let me wish you a nice afternoon